Good afternoon, everyone. Welcome to the 31st Alzheimer Europe conference and to this parallel session, learning the lessons of COVID-19 in both nursing and residential care. My name is Jim Pearson. I am the Director of Policy and Practice at Alzheimer Scotland, and I'm also an Alzheimer Europe board member. We have 5 speakers here today. I'm going to do a very brief introduction to each of the speakers, and if possible, what I'd like to do is, rather than having questions at the end of each presentation, is save that time to the end of the session so that we can have some questions and potentially some discussion. So without further ado, I'm going to introduce our first speaker, who is Sarah Swift from Stirling University in Scotland. Sarah, you happy to begin? Thank you.
So hi everyone, my name's Sarah Swift. I'm a researcher at the University of Stirling, as Jim said, but at the time that the study I'm going to talk about today was conducted, I was working at the University of the West of Scotland on a project that looked at the experiences of relatives of people living in care homes in Scotland during the first COVID-19 lockdown. So this was quite a big project across a few different universities and organisations. Just a quick nod to the project team here. And it was funded by the Chief Scientist's Office, and it was a rapid research study, which meant that everything had to be done and dusted within 6 months, which did inform some of the project decision making, as I'll go into a little bit later on. But our aim overall was to explore the impact of lockdown, social distancing, the ban on visiting and various other COVID-19 related restrictions on the relatives of care home residents in Scotland, along with care home staff members and wider stakeholders within that sector. Even though our study was conducted in Scotland, a lot of our findings are applicable beyond that context. And I also wanted to highlight that our study wasn't dementia specific, but when we were recruiting visiting relatives of people living in care homes, part of our process was to ask those people whether their loved one was living with dementia, and 2/3 of the people that we interviewed said that their loved one was. So quite a lot of their experiences were informed by the fact that the people that they helped to care for were living with dementia. So I wanted to start off by talking a bit about the overall research design. There were 4 different strands to the study. We first of all conducted 36 in-depth semi-structured interviews with relatives of people living in care homes in Scotland. In an ideal world, we would have also liked to interview some people living in care homes themselves, but as I mentioned, this was a rapid research study, and as some of you are probably aware, the ethical process for being able to conduct research involving people who don't necessarily have capacity to consent is quite lengthy, as it should be. So we had to make the decision to only speak to relatives on this occasion, unfortunately. We also held 5 creative cafe sessions, which were essentially kind of focus group style conversations with staff from 4 different care homes to talk about any sort of creative practices that they'd put in place to help carers and residents stay connected while they were unable to visit in person. We held 19 interviews with various stakeholders from across the health and social care sector in Scotland. And we also had an online survey which yielded over 400 responses, and that was aimed towards people who had a loved one living in a care home in Scotland over the time of the first lockdown. And today, my presentation is going to focus on some of the findings from the in-depth interviews that we did with relatives of people living in care homes, and just touch on some of the themes that came out of our analysis. So one of the strong themes that we noticed coming out of the interviews was that a lot of our participants were very aware of the decline that they'd observed in their loved one while they weren't able to visit. They felt that that person's physical, mental, emotional state had maybe declined more than it would have done had they been able to carry on visiting and been able to continue the caring role that they provided when they were visiting the care home in person. Obviously, it's difficult to say whether that change was attributable to lockdown and social isolation, but that was something that a lot of our participants certainly felt was happening. The importance of touch and intimacy and the impact of losing the opportunity for physical contact with your loved one was something that came up in basically every interview, as you can see from this quote from one of our participants here. And what was especially difficult for a lot of our participants was being able to see that staff members were still able to maintain that physical contact when they couldn't do something as simple as hold their loved one's hand. And we heard a lot of stories of people essentially having to use care home staff members as proxies to give their relative a hug when they weren't able to, which was quite difficult for people, especially people who weren't necessarily able to communicate verbally anymore and relied a lot on that sense of touch for closeness and communication. That was a really challenging thing for a lot of our participants to lose. Obviously, one of the things that happened when visiting care homes no longer became an option for people was that technology was introduced as a potential solution to the lack of communication. And we noticed that for the people that we spoke to, this did have advantages and disadvantages. So as you can see here, for some people, the outdoor visits that were put in place last year as a sort of interim measure between being able to visit care homes and not being able to visit at all weren't necessarily suited to everyone. The plan for a lot of care homes who allowed these outdoor visits was that relatives and their loved ones were sitting 2 meters apart, which was the physical distancing guidelines at the time, which wasn't necessarily the best option for people who struggled with their hearing or with their eyesight. And also, even though it was summer, we still live in Scotland. There were a good number of days when sitting outside for half an hour just wasn't a feasible option for a lot of people. So in comparison to that sort of awkward, difficult outdoor visit, a few of our participants said that they actually had a better experience speaking to their loved one using video calls. However, that wasn't the case for everyone. Some people, their loved ones who lived in a care home, really weren't used to this kind of interaction. They didn't really know what was going on with the video calls. They weren't really that comfortable with them. And this refrain that I've put in bold letters here was something that we kept hearing over and over again, was that it was better than nothing, but these video calls were just no replacement for actual in-person contact. And this was especially true in the context of the people that we spoke to whose relatives were living with dementia. For a lot of people, it actually caused quite a lot of distress and upset because their relative who was living in the care home couldn't necessarily understand what was going on, why they could hear the person's voice, but they weren't there in the room with them. They couldn't quite get their bearings with the technology. So it ended up actually causing a lot more upset for everyone concerned than just not being able to see the person full stop in a lot of cases. So even though technology had a lot of benefits in this situation, it wasn't quite the magic bullet that a lot of people were maybe treating it as at the time. And furthermore, what we did observe was that there was quite a dependence on particular members of staff who were able to use this technology in the first place. Obviously, being adept at Skype or Zoom or whatever people were using isn't normally part of a care home staff member's job description, and it doesn't need to be. But it was causing quite a lot of issues when all of these responsibilities were falling to one person, one member of care home staff, to facilitate all these calls. And as you can see from this quote here, it led to a lot of worry for relatives as to, well, what happens when that particular person goes on holiday, or what if they catch COVID and they have to isolate for 2 weeks and then we just don't have any communication at all. So we did develop a series of recommendations. We have published a report. I'll share the website at the end of my presentation in case anyone wants to go and download the PDF, but I'll just summarize the recommendations now. Based on what the relatives we spoke to told us, we feel like it's really important to have a more sort of inclusive, meaningful involvement of all stakeholders in shaping policy around things like COVID-19 preparedness. obviously this is not a situation that any of us are expecting to see again or hoping to see again, but it might not go away anytime soon. And one of the things that really came out in our findings was that relatives and care support organisations didn't feel like they were really involved in the process of developing the policies that were put in place and the decisions that were made at all. And it really might have made the policies more suitable and more fit for purpose and fairer for everyone involved. As part of that, we feel it's essential to have a recognition of the contribution that family carers and visiting relatives make to the care of people living in care homes. By and large, people aren't just visitors. They don't just kind of go and see the person. They help with care, they help with feeding, they give company, which are all really important parts of maintaining a good quality of life for people living in a care home environment. And one of the strong themes that came out, and it was actually a campaign that was going on in Scotland at the time, was to award key worker status to visiting relatives to really acknowledge and assign value to the role that they offer within a care home setting. We also found that most of the people that we spoke to expressed a lot of gratitude and respect for care home staff members, particularly people sort of on the ground day to day, looking after their relatives. And we feel like this supports the case for an elevation of recognition of the status of care home staff through things like increased pay, increased training. And we felt that care home staff members had perhaps been a bit unfairly scapegoated in the early days of the pandemic, and our findings really sort of contradicted that narrative. Several of our interviewees said that they'd formed peer support networks with other visiting relatives, whether that was through Facebook groups or regular Zoom calls, and that seemed to really help people and to alleviate some of the worries and concerns that people were having. So we feel like it would be helpful for care homes to consider the role that they might be able to play in facilitating that engagement between relatives. And as I'm sure we've all kind of noticed, the COVID-19 crisis for the most part exacerbated issues that were already there. And we feel that it's important for the future, when we're preparing for issues like this, to make sure that we're following a human rights-based approach and looking to see how we can counter inequalities and respect the experiences of marginalized people. And finally, we feel it's really important that there's an explicit acknowledgement of the pain that was caused to relatives and the fact that the decisions made weren't always the best and didn't work out as well as they perhaps could or should have done. And making that kind of open, honest acknowledgement might be a good first step to rebuilding the trust that's been lost throughout this pandemic between visiting relatives and care homes and wider health and social care sector. I think that's me finishing just about on time. And as promised, this is the website for the project if anybody wants to download the full report that we produced last year. Thank you.
Sarah, thank you very much. And can I just remind those who are attending this session that we'll have some question and answer time at the end of the session, but if you're connected on through the online platform, remember that you can ask questions there, or perhaps in the chat function as well throughout the presentation, and I can maybe draw attention to those at the end. And as I said, thank you, Sarah. That is something that's very close to our hearts. And in fact, our next speaker, one of my colleagues, Lorna Hart-Thomson, who's been managing Alzheimer Scotland's Action and Rights team, which was established during the pandemic, absolutely about responding to those the trauma that many people were experiencing who either lived in a care home or had family members in a care home and hadn't been able to see each other for often months on end. So I'm just going to hand over to Lorna now, who, as I said, is the head of our Action and Rights team. Lorna, thank you.
Good afternoon. My name is Lorna Hart-Thomson and I'm the Action and Rights team leader for Alzheimer Scotland. Our team was set up in February of this year by the Scottish Government to help families, carers and friends of anyone living in a Scottish care home. The team ensures families are reunited with loved ones within care homes, and to ensure meaningful contact is resumed following the COVID-19 pandemic. We help families have better information about the care home guidance called Open with Care, and we inform them of the public health restrictions within their area. We also help families make more informed decisions and have better dialogue around the care home visiting. For us to know exactly what was happening with the care home guidance, we made sure we spoke to many families. We hosted engagement sessions, online sessions. We spoke to our partner organisations, which included Scottish Government, clinical professional advisory groups. We spoke to Scottish Care, Alzheimer Scotland, but most importantly, we spoke to families, friends, residents and staff of those living in care homes. We report every 2 weeks our findings to Scottish Government, and to date we've received 260 referrals. We've had thousands of interactions, and we have listened to every single person that has contacted our team. We asked throughout those engagement sessions what it has been like, what was the COVID-19 pandemic lockdown restrictions like for families, residents and staff. And as you can see on your screen, we've got some of those direct quotes. Some residents said that it was ridiculous being kept in a room. They didn't think it was necessary because they wore a mask. Some families also didn't want to contact our team because they didn't want to make a fuss. But they were so glad when they did it because now they're getting essential visit status. One staff member reported that her job had completely changed from an activity coordinator, which was all about the resident and stimulation, to a lateral flow checker. Her job was to stand with a list of visitors, waiting to see if people were testing positive or negative before they were. That staff member knew and could see the deterioration in her residents, but she couldn't do anything about it. Every single one of the people we spoke to did not feel listened to. Some residents reported if they felt listened to, their families would have been in much sooner than they were. However, it wasn't all sadness within the care homes, as some residents told us they enjoyed just getting out in the garden for a bit of fresh air. Others enjoyed the sing-songs with the staff. And for us in Scotland, we always enjoy a blether. Some residents have mentioned they enjoyed the chat with the staff. We absolutely heard that there was a varied approach across Scotland. So there was one document, Open with Care, however, so many different approaches. There's a varied implementation to the rules and the regulations, and a different interpretation for each part of the Open with Care guidance. One, for example, the lateral flow tests. Some of our families were able to do that in the luxury of their own house. However, some were made to stand and wait at the care home whilst the positive or negative test results come back. Some families were able to take their loved ones out for the day out, to go to the beach, to go to the park. However, some were not, some were kept in the care home. Some of our families reported back that they had to speak to their loved ones through screens and keep that 2-metre distance, or at worst, have a window visit. And as you know as well as we do, people with dementia don't always communicate that well, especially if they've got other restrictions on top of that. So we have got screens, we're 2 metres apart, we're windows, and we're wearing masks. Some of our residents required to lip read, so these were just another barrier to communication. Designated visits or essential visits, there was so much different terminology and different interpretation of what that meant. Were you a designated visit that you could only get up to 2 visits per week, or were you an essential visitor that had unlimited time with your family member? Most recently, we've seen the change of a named visit status, and that was introduced as a direct result of an increase in COVID outbreaks within a care home. Families are terrified of being locked out again. However, the named visit status allows one family member to still visit during a managed outbreak. But even then, the interpretation of what a managed outbreak is different across Scotland. So for us to provide information to families to make sure they get the best information to ensure that they feel empowered, we keep them informed of what the Open with Care guidance changes are. We ensure good communication is established between families and care homes. We ensure families feel empowered to act for themselves. However, if they don't feel empowered, then the team will act on their behalf. If even then we are still finding challenges with certain care homes, we will then use a partnership approach, and we will contact people in localities to help us get a positive outcome for that family. The skilled interventions of the team enhance the quality of the visits because we strive for good conversation and not confrontation. This approach leads to much more positive outcomes. And when we hear those positive outcomes, we ensure we share that good practice across the sector. Because it might be that one care home manager is frightful or fearful of allowing more visits in. However, one might feel more confident, and it's really important that we're able to share that information across the board. One final quote to sum up the Action and Rights team. Following the call with the Action and Rights team, I then asked to resume essential visits to help the staff out, but more importantly, to help my dad, and they agreed. How simple it was to ask when you have the confidence to do it. And this was a lady who the essential visits was stopped when the new guidance came about. However, they were resumed, and that was a great outcome for her and her dad, and obviously for our team. We're happy for people to contact us after the conference and ask more, but thank you so much for listening, and we're happy to answer any questions you have. Hopefully you enjoy the rest of the conference. Thank you.
Okay, thank you, Lorna. I'm not sure if Lorna is actually still connected into the session, but anyway, we may have some questions after that. I should have said, Lorna and I both being from Scotland, that sometimes a little bit of translation might be required, and Lorna mentioned that sometimes people were a little bit concerned about contacting the Action and Rights team because they didn't want to make a fuss. I thought I might explain that. That just means they were afraid about contacting us in case it kind of created any difficult relationships with the care home provider. So any more Scottish terms, please put your hand up and let us know. I'll do my best to translate them. So our next speaker is Jasper De Witte from Belgium. Jasper is presenting on resilience of nursing home residents in times of COVID, a shared responsibility and the need for a tailored approach. So Jasper, can I hand over to you, please? Thank you.
Our research named Resilience of Nursing Home Residents in Times of COVID-19. As we all know, many restrictive measures were taken during the first lockdown to deal with the COVID-19 pandemic in nursing and retirement homes. The most important measures that were probably taken were the fact that residents were no longer allowed to receive visits, group activities were stopped, communal areas were closed, and residents were often obligated to remain in their own rooms for multiple weeks on end. The goal of these measures was, of course, to limit social contacts, infections, and the general death toll. Now, in this respect, we asked ourselves two questions. First of all, did and how did the measures affect the well-being of residents? In this respect, we base ourselves on the self-determination theory, which states that the well-being of nursing home residents is determined by three fundamental psychosocial needs, namely competence, which refers to a feeling of control and mastery, autonomy, which refers to a sense of freedom and choice, and thirdly, relatedness, which refers to interpersonal connections. Secondly, we asked ourselves, which resources did residents use to deal with those measures, which is closely related to the concept of resilience. In this respect, we looked at the resources on the individual, relational, and contextual domain. And this is quite important because it could explain variations between residents. And for example, it could explain why certain residents experienced less difficulties in this period. With respect to our methodology, this research is conducted by an international consortium of KU Leuven, Tilburg University, and UNO UMCG, so both in Belgium and in the Netherlands. And it is part of a larger qualitative retrospective study about the impact of the restrictive measures from the perspectives of residents, family members, and volunteers. In this respect, we conducted 30 interviews with residents and family members, one focus group with 10 volunteers, and 3 Socratic dialogue meetings with a mix of respondents. Concerning our results, we first see that the restrictive measures had an overall negative impact on the well-being of the residents, and this through its impact on their feeling of competence, autonomy, and relatedness. We find that, or we observe that most residents experienced a more difficult time in comparison to before, which is indicated by feeling down, having a lack of energy and vitality. With respect to competence and autonomy, we see that the general situation was characterized by much uncertainty about the contagiousness and the danger of the virus, which led to, which greatly impacted their feeling of competence, and which made many residents feel insecure, afraid, worrying, and laying awake at night. Secondly, many measures were imposed without any consultation or without giving residents and their close relatives a say, which greatly affected their feeling of autonomy. And thirdly, for many residents, it was more difficult to discuss important issues they had to deal with their close relatives, which also negatively affected their feeling of competence. Further, the restrictive measures also impacted the feeling of relatedness. This is indicated by an increased feeling of loneliness among many respondents. Most respondents missed the physical contact and simply being together, but also the practical and emotional support of their close relatives. However, in this respect, not all respondents felt lonely or more lonely than before, and this variation seems to depend on the personal need for social contact and also the ability to keep themselves busy through many individual activities. As this quote clearly states, "I participated little to all the activities which were organized in the nursing home, so I lost little." Now, when we look at the resources that residents used on the individual level, we find that the ability to accept the situation how it was is very important to regain a feeling of competence, as this quote clearly demonstrates. You needed to accept the situation. If not, you feel powerless, and that makes you sick. For this, for the ability to accept the situation, we observed that many factors were important, such as having an optimistic personality and being able to relativize, understanding and agreeing with the measures that were taken, faith and spirituality, and of course also the subjective need for social contact and the ability to do various individual activities, which is related, strongly related to the health situation of the individual residents. On the relational level, we see that a very important factor was the possibility for alternative social contacts, such as video calls, window and balcony visits, because this could greatly enhance or hinder, of course, a feeling of relatedness. Nevertheless, in this respect, many of those alternative forms of social contacts allowed less privacy, and moreover, many residents weren't allowed or weren't able to make use of those alternative forms of contact due to various health problems, such as hearing problems or dementia, and also because of various structural barriers. For example, a resident who lives on the 3rd floor who doesn't have a balcony or of course, due to bad weather. In this respect, some family members or close relatives use their discretionary space and, for example, put pressure on the management of the nursing homes to let them nevertheless enter as in the form of family caregivers or volunteers. Some of them even broke the rules and simply went outside with the residents, even though it wasn't allowed, or they asked permission of their general practitioner to do so. And thirdly, also, we observed that some residents comforted each other by, for example, playing cards together, even though it wasn't allowed at that moment. On the contextual level, we see that a first factor which played a significant role is the variations in local restrictions. While in some nursing and retirement homes, people were still allowed to go outside or could eat together in small groups with other residents, while in other nursing and retirement homes, this wasn't allowed, and they had to stay in their own room for multiple weeks on end. A second very important factor on the contextual level is the communication. Indeed, good communication, good and clear communication is very important because it enhances the understanding of the measures that are taken, and that way also a feeling of competence among the residents. Although in certain nursing and retirement homes this went very well, in others it didn't go well at all. The communication was unclear, illogical, and often contradictory, which not seldom led to conflicts with, for example, family members. Third, we observed that it's very important to give all the residents and their close relatives a say by including their perspectives and going to discussion about with them about the restrictive measures that are taken. Indeed, this can greatly impact their feeling of autonomy. And lastly, although many professionals, of course, did their utmost best and gave much extra attention and support to the residents, and they organized activities while taking into account the distancing measures, many respondents also indicated to us that sometimes professionals just had too little time, to which they weren't able to give that extra attention and support. They weren't able to allow or organize many activities, which is of course very problematic, because it meant that many residents just simply stayed in their room in quarantine for multiple weeks on end, and the professionals simply passed by to hand over the dinner and then went away immediately. With respect to the lessons learned, we first and foremost see that the measures had an enormous impact on the well-being of the nursing and retirement home residents by its impact on the feeling of competence, autonomy, and relatedness. In this respect, it is clear that it is a shared responsibility of all stakeholders involved to counteract the negative impact of the measures. And for this, we think that the nursing and retirement homes and the professionals need sufficient discretionary space to be able to develop a tailored approach and to stimulate a feeling of competence, autonomy, and relatedness among their residents. When we look at the resources that residents used or could use to deal with those measures, with respect to competence and autonomy, we think it's important to provide sufficient psychological support in order to help the nursing home residents to accept their situation. Secondly, a good and clear communication is crucial because it enhances a feeling of competence, and this could be done, for example, by installing a central information point. Thirdly, it is very important also to give residents and their close relatives a say and to discuss the measures together with them. In this respect, it's also important, for example, to consider the family as a partner and not simply as a visitor. This also will greatly enhance the autonomy of those actors. Last, with respect to relatedness, we think it's important to continue to stimulate the alternative contact possibilities, such as the video calling and so on. But also it's important in the future to take into account aspects of the building in order to enhance or stimulate more connections among the residents and among residents and other actors, such as their family members. Thirdly, many residents and respondents in general emphasize the importance to allow one visitor at all times. And also it would be interesting to allow residents to comfort each other in small groups or in pairs, because this also for some residents made a significant difference with respect to their well-being. And last but not least, it is very important to give professionals sufficient time to give that extra attention and to organize activities for the residents, because also this will have an enormously positive impact on the quality of life and the well-being of the residents. Thank you very much.
Thank you, Jasper. And it's interesting to hear from your presentation the experiences of people in care homes and families had in care homes in Belgium were very similar to the same experiences that we were hearing here in Scotland and in other parts of the UK. Our next presenter, next speaker is Victoria Tischler, also from the United Kingdom. Victoria is speaking today on the Culture Box, provisions of creative activities and public health materials to people with dementia in care homes during the pandemic. Victoria, can I just pass over to you, please? Thank you.
Hello, everybody. Yes, I'm presenting along with my colleagues, Julian West and Hannah Zelig. We're going to be talking about Culture Box. I'm going to introduce the project to start with, and then I'll hand over to Julian, who'll tell you more about the content and delivery of the Culture Boxes, and then to Hannah, who will tell you about the method and results, some of the preliminary results. And finally, we will present some reflections about the project. So firstly, to introduce the wider Culture Box team, and I want to emphasize the importance of working with a range of different partners with different expertise, featuring gerontology, music, fine arts, psychology, and public health. So firstly, some context to the Culture Box study. As we have heard, care homes have been severely negatively impacted during the pandemic, with half of all deaths across Europe during the period April to June 2020 occurring in care homes, with more deaths of those from Black and Asian communities compared to their white British counterparts. Visits from family and from professionals offering enrichment activities such as arts and music were stopped, and reports of social isolation, loneliness, and agitation in care home residents increased. Building on the promising evidence from research indicating that engagement with creative activities can benefit people with dementia, for example, through improvement in mood and attention, stimulating meaningful conversation, and enhancing relationships with family supporters and care staff. We responded to this by devising the Culture Box project using a model of co-design to produce Culture Boxes which contain creative and public health materials. And these have been delivered to care homes across England every week, both via post and digitally for 12 months. So the aims of the project then are to alleviate social isolation and loneliness, and to provide stimulating activities that enhance social interaction within the care home, and to offer accessible public health information with a focus on reaching those with dementia from diverse communities. We used participatory action research, or PAR for short, to assess the process and impact of the project. The methods used are primarily qualitative, however, some quantitative data was collected and will be analysed, but we're not presenting that today. PAR was chosen because it has helped us to capture and prioritise the perspectives of people with dementia and care staff. And now I'll hand over to my colleague, Julian West.
Thank you, Victoria. So as an artist and someone who's used to working in person with people living with dementia and their carers, my main way of working has always been through improvisation. So responding to people's creativity, using my own set of artistic skills, building relationships with and between people through collaboration. The challenge, therefore, has been to find ways to enable and encourage this approach without being physically present myself, or other artists being physically present. It seemed important to be providing resources and materials that would be interesting and engaging for a wide range of people, both care home residents and the care staff, and that could in some way encourage people to explore things together. We're also working at scale, producing materials for a large number of people, so it was not going to be possible to personalise all of these resources. So the resources and materials that we identified and created have intentionally been very diverse and across a range of different art forms. And through this diversity, we have hoped that people will pick and choose things that appeal to them, and thereby they personalise their own experience of Culture Box. We also concentrated on resources that encouraged interaction between the dyads or with other residents, rather than an activity that someone would do alone. On this slide, you can see some examples of the work that we've provided. The baobab tree, which is over there on the far left, is one of a series of 12 botanical illustrations of trees from all over the world, which are supported also by digital, video and audio material. Students at the Royal Academy of Music created a short podcast series that explored music and poetry in response to different colours. And the artist Arti Prashar was commissioned to create a multisensory piece that included sound, olfactory, and also tactile experiences. Finally, of these examples, Tommaso Del Signore's film I Jumped in the River is a short documentary film that invites viewers to reflect upon moments in their lives when they may have done something out of character or unpredictable. Many of these materials have blended physical resources with digital, for example, supporting visual and craft activity with sound or with music. And throughout, we've ensured that the resources have been suitable for diverse populations, either by commissioning artists from a variety of backgrounds or ensuring that the themes of the work have had a universal appeal. I'll now pass over to Hannah Zielig, who will talk about the methods.
Thank you, Julian and Victoria. So it's important to say that we used a participatory action research, that this is a cyclical model and that it involved 4 phases, which you can see on this slide. Were planning, action, evaluation and reflection. Our focus in this presentation is on the evaluation and reflection phases of the process, both of which are integral to PAR, and also focus on staff impact and building resilience in care homes. So we've worked with 30 care homes across England. We used dialogic interviews to collect data from a subset of our participants. These don't recount or describe events, but rather they co-construct new narratives. So research results are equally shaped by the researcher and by the respondent. We've carried out dialogic interviews with participants at 3 time points during the project. So to say a little bit about the findings then, important to know that our data analysis is ongoing. So this is really only our preliminary findings, and that to get these, we transcribed the data from the dialogic interviews, and these were obviously anonymized and then coded. Data was analysed as a team. We used thematic analysis, which supported an iterative and mainly deductive approach. So that identified findings aligned with the aims of the study, but some inductive codes were also identified. All the transcripts were read thoroughly by at least 2 team members, and then they were coded separately and together to ensure that the codes were verified. Following a thorough reading of the transcripts, 71 codes were created. The majority of these have then been collapsed into overarching code families. So we identified that culture box activities prompted discussions about shared interests, such as travel, and in some cases elicited autobiographical and other information about residents. So for example, in this quote, you can see that the participants' interest is in digital resources. They've been experimenting with the iPad. The second quote illustrates how culture box activities supported interaction between staff and resident dyads. Discussions about shared interests such as travel were very common, and topics also about nature and animals were particular favourites. So, the culture box activities provided inspiration and support for the staff during the challenging time of the pandemic, as this first quote illustrates. Culture box provided new ideas for staff who often spent their own time finding interesting ideas and sourcing materials for resident activities. And the activities in the culture boxes also influenced wider provision. As this shows, resources were shared with others who were not able to take part in the study. And I'm now going to hand back to my colleagues, Victoria and Julian, for some reflections on the project. Thank you.
Thank you, Hannah. So as Hannah described, the PAR methodology has an explicit reflection phase. in which project team notes and discussions were held, and this enabled us to alter the materials that we provided if it was warranted. And this has led to adaptation of future Culture Box deliveries. For example, the nature-based activities were particularly popular, so we increased the amount of that type of material. The second point is around remote working, which has been challenging. For example, we've experienced technical issues in undertaking interviews. However, it's also created opportunities for us to work across a much wider geographical area.
So also what's emerged is that the role of care staff has been absolutely central and fundamental to the success of the project. And for some staff, it appears that they've experienced maybe more agency and control in ways that they might not have done in projects where the artists are physically present and taking the lead in all the activities. And this has led to some staff adapting their practice, as we heard, as a result of taking part in the study and using the resources beyond the dyads, thus benefiting more people. It also has been interesting that issues of digital poverty have impacted upon the project. So despite us trying to anticipate this and providing iPads to the care homes that didn't already have them, it's still been difficult for some of the staff to access the digital content because of lack of good Wi-Fi in the care homes. And also some staff have been restricted in accessing things through a lack of training or of experience or confidence in working with digital resources.
And finally, coming back to the theme of resilience, although the impact of the project in building resilience for care staff is unclear, we believe that the project has shone a light on staff who have demonstrated resilience by working beyond their normal roles, managing crises and demonstrating strength that will support them in future crises. Thank you for your attention.
Thank you, Victoria, and thank you also to your colleagues, Julian and Hannah. No mean task, I think, with the three speakers and one presentation to keep to time. You've done a fantastic job, thank you. And our last presenter today, our final presenter, is Andrea Capstick, and presenting on living and working in UK care homes during the COVID-19 pandemic, evidence from the front line. And Andrea, if I get this right, is an associate professor at the Centre for Applied Dementia Studies at the University of Bradford. So Andrea, if I can just hand over to you, thank you very much.
Hello everybody, thank you for joining the session. There's a lot of complementarity between what I'm going to be talking about and the other speakers. But my presentation today is particularly looking at the perspectives of care staff who work in UK care homes during the coronavirus pandemic. So this is particularly looking at the perspectives of staff who were working in UK care homes during the COVID-19 pandemic. A few statistics are that the overall UK care home population at the beginning of the pandemic was in the region of 420,000 people. And between 2/3 and 75%, 3/4 of residents are believed to have some degree of dementia in care homes. It hasn't obviously always been diagnosed. Figures vary, but the latest Office for National Statistics estimates suggest that more than 45,000 deaths took place in care homes, and the corresponding proportion of those deaths that will be people with dementia then is around 30,000 plus. So a big scale of human loss in this during the course of this pandemic. Other presenters have talked about the emotional effects of people's families not being able to visit. And this is coupled with the particular irony of those measures having been taken to prevent infection, whilst at the same time, in order to release hospital beds, people with hospital-acquired coronavirus were discharged to care homes. So quite, devastating toll in terms of death and illness for people with dementia. Obviously, as researchers, we couldn't go into care homes to explore what was happening, but at the Centre for Applied Dementia Studies at University of Bradford, where I work, we run an MSc programme, a master's degree in advanced dementia studies, where all our students are practitioners working in the field of dementia care and studying part-time. So we thought that asking them about their experiences would be a really good way of getting an insight into what was happening inside care homes. And we carried out 20 online or telephone interviews with our students. We had 2 participants who were students elsewhere in the Faculty of Health Studies that our centre belongs to, but the majority of participants were students on our own MSc programme. We also had a separate arm of the project which used photo voice methods, where we asked the participants to take photographs, recording their experiences and what had helped them to get through. I'm not going to be talking about that today, but that part of the study was conducted by my colleague, Dr. Anna Barbosa, if anybody's interested in finding out more about it. We also had a patient and public involvement group of 3 family members who all had relatives who were living in UK care homes at the height of the pandemic. The key themes that came out of our data, there's a lot of very rich data from the project. It's only really possible to skim over the surface of it today. But the first one was confusion and stress related to trying to do the right thing in a situation where the guidance keeps changing. This was a really dominant theme that was mentioned by every participant. Then there was the negative impact of infection control measures on people living with dementia, as other presenters today have mentioned. There was the impact on their own mental health as time went on. We found that people were reporting primarily fear, anxiety and confusion at the beginning of the pandemic. And then as time went on, this flipped over into feelings of guilt and responsibility when residents, some of whom, you know, they would have known for many years and formed a close relationship with, became ill or sadly in some cases died. And that again then as time went on was replaced by feelings of burnout and having not having more to give, and also feelings of being somewhat invisible by comparison with healthcare workers who were often dominating news stories, and the weekly clap that took place in the UK in the first 12 weeks or so of the pandemic, that was primarily, at least to begin with, a way of celebrating the efforts of the people working in the National Health Service. And our participants said they felt comparatively marginalised by comparison with that. But there was another theme to emerge, interestingly. It was about creative coping strategies and thinking outside the box, and as other presenters again have said, developing resilience in the course of living through the pandemic. So here are a few quotes about the first thing, which was the difficulty of doing the right thing. And people talked about the fact that guidance was changing on an almost daily basis, and that having meetings where constantly changing guidance was fed back to people and they had to try and figure out what to do with it. A growing awareness that the guidance was not taking account of the particular needs of people with dementia or the nature of dementia itself, and just feeling that they were thrown back onto their own resources and common sense in order to make a judgment, but hoping that that was the right decision later on. People with dementia clearly often had difficulty in understanding the reasons for measures such as social distancing, lack of visits, the use of personal protection equipment on the part of staff, and later for mass testing and the vaccination programme. So the staff were constantly having to try to explain these measures to people with dementia, but also to justify their own actions to infection control. And this participant talks about trying to explain to infection control that they can't physically keep people living with dementia in their rooms. They can't lock them in. So what are they expected to do? The impact on their own mental health over time, the uncertainty and feeling of a looming disaster at the beginning of the pandemic, then later on losing long-term residents and questioning the decisions that had been made. Could they have stood their ground more effectively at the point where they were put under pressure to accept hospital admissions? And if they had, would people that they'd formed these lasting relationships with still be alive? And the feelings of being later on burnt out and feeling that because of staff absences and losses that there were too many of us who were trying to keep things going. But also examples of resilience, teamwork and hope. So several of the participants talked about having developed new skills in the process, being able to take on new roles and multitasking so that everybody could do everything, having to learn from each other so that they could cover for people who were off sick. And as one participant said, as much as it has caused pain and uncertainties, I remain hopeful that COVID-19 will bring about a much needed change in aged care, especially for those living with dementia. So to conclude then, this is a photograph that was taken by one of the participants as part of the photo voice phase of the study that I mentioned. There seemed to be little awareness at government level of the nature of dementia or its implications for infection control. Social care staff felt that they received less attention than NHS staff, although they had faced equivalent burdens and in some cases additional burdens. And the participants demonstrated resilience in many ways during the pandemic. We've drawn in the paper that we're writing about this, which we're due to submit shortly, on the United Nations Principles of Restorative Justice. And I think these are similar principles probably to the ones that Sarah, for example, was referring to in the first slot, about acknowledging what the dementia care workforce has had to endure and giving them appropriate recognition and reward for that. There's something very important about preserving the memories of those who've been lost, particularly given the scale of this disaster. Looking at what we can do to guarantee that this doesn't ever happen again. I mean, we can't prevent there being further pandemics, but we can put into practice some of the lessons that have been learned, and to promote healing and reconciliation and restore confidence in the institutions of the state. And part of that's about allowing people opportunities to talk about what they've lived through that don't involve either pathologizing them or blaming them. We have produced a booklet highlighting some of the key findings of our study, which is available from the link here. And we also had, during the study, a blog series, which you can also access by following the second link. And part of that is a campaign to raise the profile of care home staff, which is called Let's Hear It for Care Home Staff. Thank you very much for listening.
Andrea, thank you so much. And I just, again, thank all of the speakers, done well in time. We have about 15 minutes left for question and answers. I'd be really keen to hear from those who joined the session, whether they have any particular questions to our speakers today. And of course, you can use the online platform for asking questions, or indeed the chat function in Zoom. I'm not sure from our colleague here who's supporting, is it possible for people to put their hand up and ask a question? I'm sure. Noe, is it possible for people to ask a question by putting their hand up? Okay, I'm not sure. I have on the platform, there's a tool here which allows us to create a poll. So I'm just going to create that just now, and hopefully you can see that. Can anybody tell me if they're able to see that?
Not yet.
No. Right, okay, maybe I've got it wrong. Anyway, okay, so I maybe ask our speakers then. So one of the quite a key theme that was emerging there was around the restrictions on people visiting family members in care homes. And I know in Scotland, and from work that Lorna has been involved in with the Action Rights team, we've been working directly with families and care homes, supporting implementation of the guidance that was issued in Scotland, the Open with Care guidance. And as Lorna and others have pointed out, there's a huge variation in how individual care homes or care home providers interpreted that guidance. There was always a provision in Scotland for essential visitors to be able to have access to the care home where people were either near end of life or where they had complex needs and perhaps would be experiencing stress and distress. But again, huge variation in that. And some care homes just did not, and some care home providers just did not permit that to happen. And that wasn't a decision of staff in care homes, but maybe the care home owners, the business which owned it. As a consequence of a campaign here in Scotland, the Scottish Government have committed to introducing a right for a named individual to always be able to visit and have meaningful contact with someone living in a care home during a pandemic that we've just been through. And I just wondered whether other speakers, so the question I was putting in the poll there was, did others agree perhaps that would be a positive step, that if in a future pandemic like this, there would be a legal right, a statutory right for people to be able to have access to and visit care homes during a pandemic such as this. Can I ask, Lorna, you've been involved in that, and I know we've been campaigning for family members and carers to be seen as equal partners in care within care homes. Whether you want to maybe address that?
Yeah, thanks, Jim. I think the whole push towards this, and I can see one of the questions in the chat is very much about the inconsistencies across the board and how do we address that. And in Scotland, one of the ideas is we bring in Anne's Law, and Anne's Law is to give access throughout the pandemic, throughout an outbreak, to one family member to ensure that equality across the board. So to try and address the inconsistencies, that one family member that would be requested by the person that's living in the care home would be able to get that regular contact to ensure safety. We have had endless meetings about this because it's not without its challenges, because we need to make sure that everyone within the care home is happy with that, and ultimately it's the resident's choice. So who would the resident choose to be that person? And ultimately the main thing that everyone agrees in is that the resident is given that choice and that control, because across the board people were saying to us that they just wanted to be reunited with family members. So I'm not sure if that's happening anywhere else. They're going through a consultation period at the minute about that, so it's very early stages. So I don't know whether I've answered your question, Jim, but I think it's a difficult decision, but I think people are agreeing that something needs to be done, and we cannot possibly relive what we were living in the past year and a half to 2 years.
Yeah, thank you. Sarah, you've got your hand up. Do you want to come in?
Yeah, I was going to say, I agree with Lorna that bringing in a protection like that would be a really good step. But I think that something else that needs to happen is legal protection for care homes. So something that I didn't get to touch on in my presentation because it came more out of the stakeholder and care home interviews was that a lot of those inconsistencies were due to fears on the part of care home staff members or wider health and social care stakeholders, because care homes have been scapegoated so much at the beginning of the pandemic that people were absolutely terrified of putting any potential foot wrong. And so it was easier to just kind of close the doors completely and not put yourself at risk of anything like that. So some kind of legal protection for care homes to implement, because as you say, there was always a rule that allowed people to go into care homes in certain situations, but that was kind of not applied because there was a lot of fear around letting anybody into the care home. So I think adding sort of legal protection on that side of things as well would help too.
Yeah, and that's helpful, Sarah. And I think that's right. It's a really complex set of dynamics. Where on one hand, we had, as you say, that anxiety, I think, in care homes. And in fact, in Scotland for some months now, there's been an ongoing kind of police investigation looking at every death registered in a care home. And so care homes and care home staff are really anxious about the potential for a kind of a police inquiry. At the same time, we also had many people campaigning for a right to be able to visit people within care homes. I'm using the word visit. I know that visitor is not necessarily the right word, but I think it is that recognition of being equal partners in care. But at the same time, we were hearing a lot of really quieter voices too, of family members who not only did not want to go to a care home, but they were reluctant to see a care homes opening their doors more widely because they were anxious that either they or someone else would introduce infection. So really complex set of dynamics about how do you balance the protection from people from what undoubtedly has been a really dangerous virus, but also the recognition of the indirect harms that have come as a consequence of the measures in place to actually prevent infection as well, in which we, I think, understand much more about now than perhaps we did in the earlier months. Don't know if anybody wants to come in on that.
There was a question which I think was for me, Jim, about the rapid research study and how we managed to sort of find quieter voices when we were sort of doing things so quickly because of the nature of the study. I saw it pop up in the platform, the online platform for the conference, which I'm happy to answer if that's okay.
Yeah, of course it is. Yeah.
So obviously I admit that we couldn't possibly do a perfect job of that in the time that we had, but we tried to diversify our recruitment as much as possible. One thing that we were worried about by recruiting sort of through care homes was that we might end up only getting the voices that the care home management wanted us to hear. So instead we sort of cast our net a bit wider and we did our own screening to bring people into the study rather than relying on care home managers to do it for us. They just kind of sent out the initial communication for us and we took it from there. And we also went through various different networks that the project team had to make sure that we were recruiting from a variety of different care homes, sort of management structures. So we couldn't go through NHS care homes, for example, just because there's different ethics required for that. But outside of that, we went through care homes that were managed in a variety of different ways. So we were capturing different experiences. And the online survey as well, the part of the reason that that was put in place was to make sure that we were capturing as many perspectives as we could, because obviously we were limited, even with such a big research team, as to how many interviews we could conduct in such a short period of time. So the survey helped us to try and ensure that we were listening to as many people's voices as we possibly could in that time. But had we had more time, obviously we would have liked to have included, more perspectives, but it was just the nature of the funding call. Unfortunately, it was entirely practical.
Okay, thank you, Sarah. And I can now see the questions. So there's a couple of questions here regarding Culture Box. There's a few comments and just positive comments, and in here, but so one for the team around Culture Box. So there's a specific one for you, Hannah. Can you explain what a dialogical interview is? And also regarding the Culture Box study, were participants involved in all 4 parts of the PAR cycle?
Yeah.
Oh, Hannah, you go ahead and I'll come in after.
Oh, sorry, I was going to answer the dialogic interview question. So it's a very particular, I'm going to put my video on. It's a particular kind of interviewing technique that is really, as I described, it's not got a semi-structured format. It doesn't have a fixed schedule. So we had, for each dialogic interview, we had 4 areas that we would like to discuss. So it's very, very loosely guided by our interest in the Culture Box study. But ultimately, if the interview doesn't follow those kind of themes or they don't come up, then they don't. And it's really guided by the person with dementia or the care home staff. So it's really about what they would like to talk about in relation to Culture Box, preferably. It's a really interesting way of interviewing people because it throws up a huge amount of unexpected ideas and themes and areas that we wouldn't have overtly looked for. But I don't know if you want to say anything more, Victoria.
Yeah, just to add that you know, I had some real concerns that how well we'd be able to engage with people using this type of interview technique remotely, but we've had some really interesting and in-depth interviews with people with dementia in care homes and with care staff. So, you know, despite the technical issues, we've managed to get some really rich data. And then moving to the involvement of people with dementia in PAR, we had a co-design group at the beginning of the study, and that incorporated people working in care homes and some people living with dementia as well, who supported some of the initial ideas around, for example, the branding, the design of the boxes, some of the contents as well. And added to that, people are involved in the reflection phase. So where things have come up in the dialogic interviews, as a team, we discuss some of that feedback, and then that's fed into the next planning cycle so that things can be changed iteratively. And that was really important, for example, with the public health information, you know, where it was very dynamic and changing, but also where we found things that worked better than others, we were able to change the delivery as we moved on. Okay, thanks for the questions.
So we've only got about a minute left, but there's a couple of other questions. Maybe so one of them relates to about lockdown situation, still very much in for many care homes in Scotland is still an issue. But one of the themes that came up was that most of the presenters had mentioned inconsistencies in how guidelines were being interpreted, and how can we address that? Would someone like to maybe respond to that one? Hi,
Jim. I'm happy to come in. I think the learning of the last nearly 2 years has been paramount over this, and we are noticing the inconsistencies are getting less from the learning. I think the issue is each area is completely different, each care home is completely different, and just very rightly, as Andrea and Sarah had mentioned about the fear of staff, and it's building that confidence up with staff, and so that it's not a blame game. And it's basically, we need to get communication better. We need to ensure
Sorry to interrupt, but it is time and I have to go to another meeting. So we'll have to stop this meeting.
Okay, can I just thank everyone for their participation, and for all of those who joined this session as well, and to our speakers, thank you so much. And it's been a pleasure spending the last hour or more with you. Thank you.